welcome to today's session. We have Dr. Shagorika Mukherjee, eminent endocrinologist from Kolkata with a vast clinical experience over years. Today's discussion, we would be addressing the cardiovascular continuum, that is a part and parcel of the natural history of diabetes and the contemporary context. Dr. Mukherjee would like to hear your experience on a couple of issues. Most importantly, during the COVID pandemic, we have lost quite a number of young people quite prematurely. And looking into their file and data retrospectively, we could see probably we've been addressing the cardiovascular issues of such young subjects who are coming to us maybe with diabetes or thyroid disorders and other things quite suboptimally. What is your impression on such things?
Hello, it's good to get connected. Cardiovascular disease associated with diabetes is very, very topical, which we did not used to pay too much attention in the past. We used to think that diabetes is just a metabolic problem concerned with your blood sugar levels. Maybe you have to take a little bit care about your blood pressure and maybe a little bit about your cholesterol levels as well. But now, as we have the science of diabetes evolving, as the biology of diabetes is being evolved, we now understand that cardiovascular disease takes a very, very prominent part in the life of the diabetic patients because cardiovascular disease is the ultimate cause of mortality of type 2 diabetes patients. So if you see that during the COVID times, a lot of young patients succumbed to COVID associated infections. And these patients really had very poorly controlled diabetes. And looking retrospectively, you could also see that they also had hidden cardiovascular load in the form of some degree or other of heart problems, either in the form of myocardial diseases, atherosclerosis, high blood pressure, dyslipidemia, and so on. So initially, we have been attempting to control their blood sugar level, but not paying so much attention to cardiovascular protection. And maybe this has taken toll during these times, and the young patients have succumbed to catastrophic.
So taking the cue from your wonderful words, should we be looking into the molecules that we use, not necessarily only the glucocentric approach that use any molecule to reduce the glucose load, rather should we be choosy about, rather be more specific while choosing our combination of drugs that we will be using, having proven cardiovascular data? And how do you consider drugs which have got definite mortality benefit data like empagliflozin, which has got a robust cardiovascular as well as renal protection data? What is your opinion in such situation?
Right. The traditional teaching for diabetes management used to be that you have to lower your blood sugar levels down. And once you lower your blood sugar levels down, you achieve a good HbA1c, which reflects your long-term mortality, might reduce your microvascular problems like retinopathy, neuropathy, nephropathy. But from cardiovascular standpoint of view, lowering HbA1c did not really have any that much of effect, as it was revealed by the previous ADOPT study, VADT study did not say that just lowering your HbA1c will help you to achieve cardiovascular health. But of lately, we have got some wonderful molecules in our hand, which is making a positive impact on cardiovascular health, like reducing major adverse cardiovascular events, reducing incidences of heart failure, further worsening of heart failure. Not only that, these molecules are also improving the renal parameters. And when I call this molecule, these are the SGLT2 inhibitor, which are the newest kind of anti-diabetic agents which have been introduced into the market some 5 years ago. The clinical trials on SGLT2 inhibitor, and after launch of SGLT2 inhibitor, there were other trials carried on which reflected that your cardiovascular health immensely improves once the patient gets started on these agents. And this improvement comes on very soon after the agents get started on the patient. So I would say that within a period of a few months. So in an uncontrolled type 2 diabetic patient, or even in a newly diagnosed type 2 diabetic patient, when you start medications which have complementary mode of actions like metformin, SGLT2 inhibitor, DPP4 inhibitor, together, then what are you going to do is not only have a positive impact on improving their glycemic control, but also it will take control on the cardiovascular deterioration of the cardiovascular health. It will improve the cardiovascular health, and the overall mortality of the patient is going to improve because their cardiovascular health status is going to improve. So a combination of SGLT2 inhibitor, DPP4 inhibitor along with metformin is a very, very synergistic and complementary method of treating the patient so that you can get him to glycemic goals as well as treat his cardiovascular risk factors.
So how early should we be adding fixed dose combination in view of especially considering those patients who come with pretty high base level A1C, maybe 8.5, 9, 9.5. How early should we be putting these FDC of say DPP4 inhibitor like linagliptin and SGLT2 inhibitor like empagliflozin, which has got definite renal protection as well as mortality benefit data?
It's been shown that the longer you leave that patient in uncontrolled hyperglycemic state, the worse is the development of complications associated with diabetes. So quicker you get them to target, you achieve your mortality benefits the quick in a much, much better way. So even for a newly diagnosed patients, after their screening and after starting them on diet, lifestyle and metformin, if they remain uncontrolled, combination of metformin and DPP4 inhibitors can definitely be started on them. This is also true for that patient who has remained diabetic for a prolonged duration of time. And if that uncontrolled diabetic patient is also started on DPP4 and SGLT2 inhibitor combination, like an empagliflozin and linagliptin combination, they will also have a positive benefit from cardiovascular point of view as well as renal point of view.
Suppose someone comes with 9 or 10 such A1C, and we all come across patients having who are large eater, OVs, having multiple risk factors. Should we be adding such OADs one after one sequentially, or early adoption, or rather early intensification with a fixed dose combination would be helpful in such scenario?
When you're adding one OAD or one oral agent one after the other at tandem, what you're going to do is actually pushing the patients towards glycemic failure. Because before this add the second agent, it's already about 3 to 6 months. So you're leaving the patient for 6 to 8 months in the hyperglycemic period. So it will take another 1 year for the third agent to get added. So another year gone, which means that the patient is staying in a hyperglycemic state for a prolonged duration of time. And this prolonged duration could actually mean 6 to 8 years before the patient's treatment get optimized, by which time his cardiovascular risks have already built in and he doesn't get any protection. So instead of that, if you start the patient from complementary and synergistic medication like metformin plus DPP4 SGLT2 inhibitor from the beginning itself, even in the patient who has got uncontrolled diabetes, like as you mentioned, A1C of 8.5, 9%, 9.5%, even in these patients as well, we see a robust improvement in their glycemic status, as well as in the long run, there is improvement of their cardiovascular health status. In fact, the higher your HbA1c that you start your medication, the better improvement in their HbA1c that you can see than starting on lower HbA1c. But it doesn't mean that at lower HbA1c you cannot start on these agents. These agents also work very well at lower HbA1cs as well.
So, what will be your consideration in terms of patient factors that will be thinking while choosing such a combination therapy? Whom would you exclude? Whom would you include? Other than everyone having quite a robust dysglycemia.
As far as linagliptin goes, linagliptin has got a wide variety of yeah, the horizon is quite wide that you can pick and choose your patient from a wide variety of patient, no matter what sort of complications they have, like hepatic complications or renal complication, because linagliptin doesn't affect your renal status or hepatic status, which is the main mode of excretion of medication through your body. So linagliptin can be started in the young, old, or even in the moderately controlled diabetic patient, or even in the middle-aged patients as well. Regards to SGLT2 inhibitor, you have to keep in mind that you must have some degree of renal preservation before you start SGLT2 inhibitor. Previously, the cutoff EGFR used to be 45, but now the EGFR is 30 before you can start an SGLT2 inhibitor. And make sure that the patient is well hydrated, patient is not in an acute state, say for example undergoing a surgery, recovering from a trauma, or in a hospital intensive care setting. Then because of excessive diuresis, because of the PKPD of action of SGLT2 inhibitor, may cause a little bit of fluid loss, and that may make things a little bit here and there. So for SGLT2 inhibitor, make sure that the patient is well hydrated, has got a preserved renal function, and does not suffer from recurrent genitourinary tract infection and urinary tract infection. And linagliptin can be started as much as any patient with diabetes.
Very quick two questions. First question, say for example, someone have undergone cabbage. How early following a coronary bypass can we initiate such combination?
Once after CABG patient comes out of intensive care, he can be started on SGLT2 inhibitor inside the ward, definitely before the discharge of the patient from the hospital.
And should we be looking for any other issues like requirement of other comorbid agents like ARBs, ACI, ARNI while choosing? Because we sometimes come across that some patients have their BP drops after the use of these things, especially in elderly. What are the considerations one should be remembering while putting a sick person on these combinations?
Far as linagliptin is concerned, you can really rest assured that linagliptin will not upset any of your systems in the body, and it can be used in utmost of hepatic impairment or even renal impairment up to the point of end stage renal disease. Even patients on dialysis can be just well controlled on linagliptin. When you consider SGLT2 inhibitor for the elderly person who has got a preserved EGFR of above 30, you can start them. If the elderly person is using a diuretic, be cautious that a diuretic might cause an excess of fluid loss, and therefore you want to stop the diuretic. In the very hot summer months when patients are sweating too much, advise the patient to drink extra half a liter of water so that they could compensate for the fluid loss. If the person is going through recurrent genitourinary tract infection or urinary tract infection, then definitely SGLT2 inhibitor has to be stopped. But these infections are not so serious, can be well controlled with outpatient antibiotics.
And obviously, probably there is data to suggest that combination reduces risk
Data
of
definitely combinations reduces genitourinary tract infection because the combination therapy with DPP4 inhibitor inhibits the DPP4 enzymes in the yeast and the fungi and the bacteria and reduces their proliferations.
and also reduces the glucose load that's coming out of the GU tract and thereby reduces the risk. So, in overall, how frequently we should be monitoring such patient and whom should we exclude? Say, for example, someone who has got a very high fasting sugar, should we be adding basal insulin on top of it just in order to avoid the risk of euglycemic decay and similar complications?
Person with type 2 diabetes, definitely you can add SGLT2 inhibitor and DPP4 combination to this person, and you can add basal insulin in order to reduce the hyperglycemic load, not for the euglycemic ketoacidosis. But for the type 1 diabetic patient, SGLT2 inhibitor can be used, but under those circumstances, be mindful never ever to stop insulin, because once you stop insulin because of improvement of the glycemic status in type 1 diabetes where you are using SGLT2 inhibitor, there you run the risk of giving them euglycemic ketoacidosis, but not so much for the type 2 diabetic patient. But as the glycemic status is improving, you can reduce the insulin dose or make adjustments in the other treatments.
Especially those patients who are having a long duration of diabetes, who are actually beta cell depleted,
Insulopenic. Yes.
insulinopenic patients.
Yes, in those patients, you can reduce the dose of insulin, but stopping the insulin completely might not be very
Will
prudent.
be risky.
Will not be very prudent.
Just a very quick just reminiscence. We have got couple of other SGLT2 inhibitors beside empagliflozin, and probably each one came up with their data set, and some of them are quite reproducible, while some of them are not. Now, canagliflozin probably came up with a quite significant amount of fracture risk, while remogliflozin probably doesn't have any significant cardiovascular data, while atugliflozin probably failed miserably in the VARTIS-CV trial to prove any cardiovascular outcome. So essentially, would you reiterate that not necessarily all SGLT2 inhibitors are equal, or they are not really equally protecting? Should we be sticking to EMPA as our first choice because of the robust data, both EMPA, REG, EMPRISE, and all other studies followed by them?
Regards to remogliflozin, there isn't any long-standing or a robust cardiovascular data to back it up. So I really cannot comment on them. Regards to the other SGLT2 inhibitor, EMPA, CANA, DAPA, and autogliflozin, if you notice the clinical trial details, the type of patients that they had recruited, the methods of statistical methods were used for analysis, the follow-up of the patients were absolutely different, and there was no head-to-head comparison of any of the SGLT2 inhibitor. So, like empagliflozin in the EMPA-REG trial, the recruited patients were very sick. They had high cardiovascular load, long-standing diabetes. So, it was essentially for those persons who were very, very sick, and it made a robust impact on these patients. The CANA patients, they had patients who were and the primary prevention group as well as secondary prevention group, as well as it produced better renal data to start out with. Whereas with the DAPA group in the declared TIMI trials, 40% of patients had secondary prevention and 60% of patients were in the primary prevention group. So their recruitment of the patients were quite different. The patient groups were different. Statistical methods were different. Follow-ups were quite different. So it's very difficult to really be judgmental about each of the one particular SGLT2 inhibitor.
And your take on the newer class of molecules which is coming up quite frequently, like the GLP-1 agonists that we are getting to use, the oral version or the injectable version. How do you consider them faring, other than the cost issue, overall stroke prevention, cardiovascular prevention, renal organ protection thing? Do you consider them to be equivalent or anything plus minus?
Okay, the trials with GLP-1 receptor molecules, they are an extremely robust molecule, and the cardiovascular outcome trials with GLP-1 receptor agonists favored more towards stroke reduction rather than cardiovascular reduction, than heart disease reduction. So stroke reduction was much better with GLP-1 receptor agonist, with the injectable GLP-1 receptor agonist. Cost is definitely an issue. Being an injectable therapy puts the patient off. Patients are not very forthcoming or not very willing to try on injectable therapies. So, which means that, and if they're providing the same sort of benefit, then people usually want to try on to SGLT2 inhibitor first than GLP-1 receptor agonist, given the cost issue. Injectable varieties and the oral varieties obviously out now, but again, it's quite costly. So,
and also the retinopathy issue.
The retinopathy issue is already there.
And how safe would be this combination in pregnant women? Can we try them?
Well, it's not been tried on pregnancy. The age-old medication for pregnancy is still insulin and maybe metformin in the first trimester.
Thank you so much for the presentation. We would just like to have a one-line summary about this combination and tomorrow's message, tomorrow's way to look for how you address the issue in just a single line conclusion.
For a type 2 diabetes patients, when you think about, just not think of controlling their blood sugar level, but in the long term, think about how can you reduce the mortality by reducing the risk, by reducing the cardiovascular disease, and give them combination medicines which will not only address the hyperglycemia, but also reduce the cardiovascular risk profile. And in the long run, always emphasize making sure that the patient is compliant with your medications.
Dr. Mukherjee, really thanks a lot for such a nice, lucid, and very informative presentation for today's session. Thanks a lot once again.
Thank you very much. Thank you.
Thank you.